Hi, this is Brian Wormers recording a lecture for about the care of patients with urinary problems, specifically kidney disorders, for medical surgical nursing at the University of Sioux Falls. Some more learning objectives for this. We'll be talking about kidney disorders, including congenital disorders. We'll talk about infection and some of our diagnostic testing for that. We're going to talk about kidney disorders and what are some of the priority nursing interventions. And then finally, we're going to talk about education about kidney function and other health problems. As an overview, polycystic kidney disease is an inherited disorder. The bad thing that happens with this one is that the cysts eventually will lead into kidney dysfunction because the cysts develop in the renal tubules and cause these glomerular and the renal tubulars not to function correctly. And so that's bad enough in and of itself, but the other thing that can happen is that these cysts can grow too big and they can rupture, and then they cause bleeding and infection and other bad aspects of it as well. So, concomitant with this, oftentimes people with polycystic kidney disease often have hypertension. It's kind of did the erythropoietin and the damage to the kidneys cause the hypertension, or did the hypertension cause polycystic kidney disease? And there's thoughts both ways on that. So assessment, we're looking for history. We're looking for any back pain, flank pain, distension, constipation issues. Constipation, surprisingly enough, is one of the main things that people will say for admission, because when they have this, the kidneys get enlarged, it pushes on the bowel, and then that leads into constipation. Hypertension is another issue with this, changes in urine output, decreased filtration ability, headaches related to hypertension, and nocturia. Objectively, so we might see that kidneys are bigger, you can palpate them, the abdominal girth is bigger, and they have some distension with this. They might have bright red blood that they're voiding out related to rupture of the cysts, possible UTIs, and of course psychosocial responses might vary depending on what they all see with this and what's going on. Laboratory assessment of this, so clean catch urinalysis, looking for protein, hematuria, infection. We can do an ultrasound, CT, MRI to detect any of those cysts. And we might do an IV pyelogram, so we're injecting dye into the vascular space within the kidneys to see how the perfusion is going. Interventions, we're looking at trying to do pain control with this as much as possible. We do want to avoid some of the meds like NSAIDs and ASA because of the nephrotoxic compatibilities of this. Aspirin's also got the bleeding component of this that we really want to be careful with. Constipation, so trying to prevent constipation with stool softeners, increased fiber, increased fluids. Controlling hypertension with sodium restriction, drug therapy, and some home recording related to monitoring blood pressures. Finally, hemodialysis if it progresses into chronic kidney disease, which we talk about in a different presentation. So hydronephrosis is a major risk factor for damage to the kidneys, and so somewhere along the line there's an obstruction. So this could be related to kidney stones or pressing on the ureters or anything along that urinary tract. So within this, some of the pyelonephrosis assessment that we'll be doing is looking for a history of UTIs, because UTIs can be ascending in nature and can damage the kidneys. Diabetes mellitus, of course, with that increased sugar and decreased perfusion, can cause complications. Renal stones and immunosuppression, all those can lead into pyelonephritis. So history of present illness, so fevers, chills, flank or back pain, CVA tenderness, nausea, vomiting, and colic pain are all part of this. Subjectively, we look at tachycardia, tachypnea, CVA tenderness, kidney enlargement. Diagnostics, good UA/UC, looking for leukoesterase, sign of UTIs, and that pathway. Blood cultures to see if they are uroseptic at all, CTs and scans with ultrasound, looking for any abnormalities on the kidney. Then we can do voiding cystourethrogram. So we can insert a catheter and then inject dye into the bladder and see if that is coming, if it stays in the bladder and comes out, or is it having back pressure and going up the ureters into the kidneys. So pain is a real function with this one, so of course we want to monitor that and treat it effectively with drug therapies, distraction techniques, nutrition, and if it's bad enough, then we might have to do surgery to correct whatever structural problem is wrong with this. Potential for chronic kidney disease, so yes, if this keeps on going, then yes, it can turn into chronic kidney disease. And of course, we don't want that. So what do we do with this? If they've got a UTI, of course, we're treating with antibiotic therapy. If they've got hypertension, we're trying to control the blood pressure. And then, of course, we're going to do a lot of education with telling them about kidney dysfunction and what to watch for, but also preventative, trying to get them to save their kidneys as much as possible. Glomerular nephritis is inflammation of the Bowman's capsule. And so this can be either primary through genetics or immune, but I've seen it more commonly with secondary disease, with the vasculitis infection taking place and then causing this. So a lot of different forms, but oftentimes it's immune complexes. And so where we see this a lot is, your strep throat, recent upper respiratory infections and stuff like that. You get those immunogenic bodies that seed in the kidneys, and your body attacks those kidneys because it thinks it's got an infection within it. So other things that could happen with this, so you want to see if they've had a history of infection, illness, surgery, travel, for weird viruses, bacteria, fungi, or parasites, any autoimmune diseases such as lupus. History of present illness might include swelling, shortness of breath, changes in voiding patterns, or hypertension. Objectively, we'll probably notice edema, crackles in the lungs, S3 heart sounds, and JVD. Diagnostics, so UA, UC, looking for a decrease in GFR, changes in BUN and creatinine, and then ultimately we'll do a biopsy to look at the cell tissues themselves and see if they're damaged. Intervention, so prevention of complications using patient education, so tell them about the drugs, why they're using them, when they're using them, what's the time frame for those. Talk about complications related to sodium and water restriction, medications that they're on, and diet. Plasmapheresis can be a tool for this one if we want to try that. So take out the blood and wash it. And then, of course, dialysis if necessary, if it leads into end-stage renal disease. So that concludes this lecture. If you have any questions, please contact me.